Thank you so much for joining us today for our latest edition of our Women with Heart Online series. So today we will be talking about the history of breast cancer, and we'll have a Q&A with Dr. Harvey Schipper. So we're very, very excited for today's talk. So our speaker is Dr. Harvey Schipper, who is a professor of medicine at the University of Toronto, and he's been involved with the Toronto Rehab Institute in the breast cancer program for several years. So just before I hand it over to Dr. Schipper, I do want to go through our ground rules. So these sessions are for education only. We ask that you connect with your healthcare provider for specific advice about your situation. We will answer questions generally, not personally, and we may not get to all questions today, but we will do our best to answer them as soon as we can and post them online. Okay, so without further ado, I will hand it over to Dr. Schipper. You've got your video on there, and so I'm going to stop sharing my screen and we'll start again later.
I'm Harvey Schipper. I'm an oncologist. I've been involved in breast cancer research and treatment and teaching and writing for a long time. And for the past several years, I've had the privilege of being involved with Toronto Rehab's breast cancer rehab program, which mixes exercise and education and other things for women who are traversing the trajectory of having had breast cancer. We've seen women come into the program right at the beginning of their history, right at the time of diagnosis, and also women who've joined the program many years later. And it started about 10 or 12 years or more ago, before I was involved, as an offshoot of a cardiac program, because someone made the observation that women who have breast cancer put their lives kind of on hold. They're getting their treatments, and they're sitting, waiting for, if you will, the sword of Damocles to fall, wondering what the side effects will be, what their hair loss is, how they'll feel. And someone said, why don't we just bring people together, give them some exercise and a chance to come together and not feel quite so alone and see what happens. Well, as it turns out, that has certainly worked. The program has grown over the years. But another fascinating thing has been observed, not only in Toronto, but in other places that are doing this, and that is that people who get involved in programs like this, who have a moderate exercise program, and we're not talking about Olympic training here, just a moderate exercise program that's individually tailored, seem to have a lower risk of the breast cancer coming back, in addition to whatever other treatments they may have been receiving. So something that started as an idea that was kind of an intuitive, simple idea of getting people together and getting us sort of out of ourselves has turned out to have much greater potential benefit. And as I got involved in the program, it became clear that a lot of this was not really surprising if you thought about the whole history of breast cancer and our understanding of it and how it's influenced our treatment over a long time. So during this program, and some of you may not be registered in the program, others will already know me from going around the track, we've had a series of talks. And nominally, there are about 6 of them. And they have a topic like the history of breast cancer, or how we plan your treatment, or what it's like after the end of your treatment. But what often happens is we get together and this starts on a topic, but because we're in a room together, we know one another somewhat, we actually end up having some very interesting discussions that people find very helpful. And frankly, I find a very powerful learning experience for me. I think it makes me a better physician along the way. So we're going to start that way today. And because the format is a little bit new and we're not quite used to it, it won't be quite as relaxed, if you will, and informal as sitting in the room on Rumsey Road. but we'll see how it goes, and save up your questions, put them in the chat room. We'll try and answer them and try and get a bit of a conversation going. And over time, you know, we'll evolve the program, we'll evolve the technology as we learn. The first recorded case of breast cancer goes back to Babylonia in the time of Hammurabi, when on one of the cuneiform tablets, there seemed to be reference to a lump in the breast. Later than that, in the days of the Ptolemies in Egypt, there are clear stories of breast cancers and attempts even to surgically remove them. There are descriptions of lumps and bumps, and the whole notion of tumor, dolor, rubor, in other words, a lump, pain, and a discoloration of the skin, came into the language. So this goes back a very long time, and whatever the medical model that was being used then, however people thought of the disease, the perception was that this was a lump that had really serious possibilities of causing not only disfigurement but death, and it stimulated all sorts of therapeutic responses, including surgical responses. And as you can well imagine, the surgical technologies were nowhere near as good. So we didn't have anesthetics, we didn't have good sutures, and we certainly didn't have much in the way of pain relief. We started to understand breast cancer a little differently and a little more anatomically with the invention of the microscope, and our ability to now look at the body not only grossly, as in autopsies or in examining rooms starting in the Middle Ages, but with the invention of the microscope, we started to look at it in a much more detailed, close-up kind of way. And even in these later days, the same surgical approach applied. This lump had to be removed. And I don't know if any of you happened to see the quite remarkable television series called John Adams with the brilliant actor Paul Giamatti, who played President John Adams of the United States. In one of the episodes, there's actually a visualization of his daughter's mastectomy done in the 18th century. And, you know, it's quite dramatic on the screen. And was a mastectomy because at that time, that was the point of view, and it continued to be the point of view as medical technologies improved. So with Lister's discovery that antisepsis made a difference, with the introduction of better pain control, the technologies of surgery expanded, the surgery became less hazardous, and its extent also increased over time. That surgical technology kept increasing well into the 1960s and 70s, because the concept at the time was that breast cancer started in the breast and that it spread centrifugally. So a little lump in the breast became a bigger lump in the breast and a little bigger lump in the breast, and then it spread to the nearby tissues, and then it spread to the lymph glands like the wave in a pond after you dropped in a stone. So the natural extension of that kind of understanding of breast cancer was that the larger the surgery, the better the chance of controlling the disease. And it reached its maximum in the 1960s and 70s with Jerome Urban's extended radical mastectomy, where in fact they removed the breast, all the muscles on the chest wall, all the lymph nodes under the arm, and they did it using a term they called en bloc. In other words, in one piece, because of concerns that if you did it otherwise, you would spread the tumor. And in addition, they knew the anatomy and that the lymph nodes of the breast not only drained under the arm, but drained behind the sternum, behind the ribs, in the chest, kind of beside the heart. So the extended radical or urban mastectomy included splitting the sternum, opening the chest, and taking out the internal mammary lymph nodes. The consequences of that surgery were, of course, pretty extensive change in a woman's anatomy. That chest wall was now devoid of all of its soft tissues, and often you got big, fat, swollen arms because of interruption of the lymph nodes, the lymph node drainage. Well, while all that surgical advance was taking place, there were other clues that something else was going on. And as often is the case in science and other things, different patterns of thinking run in parallel. They touch, they separate, they come back together. And there was a sense for a long time that breast cancer had something to do with female hormones. Clearly, because it was in a female sexual gland, the breast, but also because of its pattern around, typically, but not always, around menopause, and how it somehow fluctuated to a certain extent. And in the late 1880s, as surgical techniques evolved, there was a surgeon in the UK by the name of Beatson. And he would see patients with breast cancer that was advanced, that had spread to other parts of the body. And he did a surgical thing. He thought, well, if this is in fact a hormonally responsive kind of tumor, what would happen if I removed the ovaries of women who had advanced breast cancer? So he did. And strangely enough, for many women, the breast cancer regressed for quite a period of time. So now you have two parallel thoughts. One, that the cancer starts in the breast, spreads uncontrollably, slowly, a little further from the center every day. And so we have a large surgical experience. And the other notion that this is not really a totally independent process. It actually is under control by some mechanism from hormones. Because if you took out the ovaries, it regressed. So these two ideas are running in parallel. Fast forward to the beginnings of my career in the 70s. And we were doing as extensive surgery as the technology would allow. Then there was no other treatment thereafter until the tumor may have recurred. And what was our treatment at the time? Our treatment at the time was that if the cancer recurred and you were premenopausal, we would take hormones away. How would we do that? We would remove your ovaries. And in fact, there was a whole sequence of surgical procedures that were designed to do that as the disease progressed. They would remove the ovaries, they'd remove the adrenals, and they might even remove the pituitary gland. If you were postmenopausal, then the treatment was to give fairly high doses of an estrogen called diethylstilbestrol. And that really worked. And it worked, interestingly enough, in the same proportion of women who had advanced breast cancer, as we learned subsequently, turned out to be estrogen and progesterone receptor positive, because we didn't have the test then. So here's those old ideas moving forward to a more modern kind of technology at the time, where we actually used hormones, and strangely enough, we actually gave estrogen with very good effect, though transient, in women who were postmenopausal. There were two renegade physicians in Pittsburgh, the Fisher brothers. Eddie was a pathologist, Bernie was a surgeon. They both became very close friends of mine. I worked with them for a while In fact, Dr. Bernard Fisher died a few months ago at the age of 100. And they were radical thinkers, and they looked at this data. They obviously were highly trained in the area. Bernie was a breast cancer surgeon, and Eddie's was a pathologist whose focus was on breast cancer. And they said, gosh, we're seeing this whole range of surgeries, mastectomies, extended radical mastectomies, but the disease comes back. It doesn't make a lot of sense. And is that really what's going on? And so they put forth a different kind of idea. And it said, yeah, the breast cancer starts in the breast, but it spreads widely throughout the body from its very beginnings. It's a systemic disease. And what determines whether the disease comes back and where it comes back are the individual properties of the tumor and the relationship between the tumor and the particular host. So not all breast cancers were going to be the same. Some would be very aggressive. Some would be very indolent or slow growing, as we use the word. And if the hypothesis was true, then the extent of surgery was kind of irrelevant. So over a period of years, they and subsequently others did a whole series of experiments that actually demonstrated in animals and in people in many ways that at an experimental level, that was true. So that takes us back to the late 1970s when first Gianni Bonadonna in Italy, but at the same time Bernie and Eddie in Pittsburgh said, I think we need to test this hypothesis. And how are we going to test the hypothesis? Well, we are going to propose a trial where some women at random have a mastectomy and some women equally at random have a lumpectomy, and there was a third group that was going to add local radiation to the lumpectomy. This was a hugely controversial trial because the accepted wisdom of the time was you had to have the most extensive surgery possible. The standard of care was based on that centrifugal growth model. But they were able to convince the National Cancer Institute and others, and in particular, Canadian investigators, to participate in the trial. And in fact, about 2,500 very brave women over time entered the trial. Now, what was really interesting was when that trial started, and I was part of that trial's execution and analysis, when the trial started, we could get very few people to enter the trial. The surgeons were saying, how can I do this? It so flies in the face of everything I believe. But gradually, as some laboratory data came out, with the endorsements of the National Cancer Institute, with the development of the clinical trials and analysis process, where we could see that we hadn't made a great deal of progress in treating breast cancer, the numbers started to go up. There were some little things we had to do to make the trial a little bit more appealing, and we can talk about that if people would like. But suddenly the accrual went up. And after about 2.5 years, we were 2/3 or 3/4 of the way to our target number of about 2,500 people. In other words, 700 or 800 people in each group, when suddenly accrual fell off. And why did accrual fall off? Because absent any data, hard data, there was a shifting perception that maybe breast cancer was a systemic disease. And maybe we didn't need to do this kind of surgery. So the same surgeons often who were saying, oh my God, I can't enter a patient at the beginning because how could I do the lesser surgery? Are saying, how can I do this more extensive surgery? So it was a little bit hard to finish the trial. But when the trial finally was finished and the data came out, we demonstrated then, and now we have about 35-year follow-up data that says a lumpectomy is the equivalent of a mastectomy from the standpoint of overall outcome of breast cancer, provided, of course, the lump was of a size at the beginning that you could do a mastectomy, that you could do a lumpectomy. And radiation also made its contribution. So suddenly, that part of the biological model changed. What was happening on the treatment side? Well, we were in the days of chemotherapy, and chemotherapy, of course, started with the leukemias and with Hodgkin's disease, and the notion that if you gave these cancer-killing drugs early, you were more likely to kill the cancer cells. And it was based on an interesting animal experiment. And it was conducted in mice many times in many different ways. Some mice spontaneously developed breast cancers, others had them implanted. And what they found is when you took out what we call the primary tumor, for a period of time, the metastases, the parts of the tumor that were left behind, grew more quickly, as if the primary tumor had some suppressive effect on tumor cells elsewhere in the body. There was a kind of window, and it was a window of a couple of weeks in a mouse. It's a little hard to translate that into people, but it was the basis of the thinking about adjuvant chemotherapy, meaning chemotherapy that we give without any evidence of the tumor being there. In other words, the primary tumor has been removed, but in theory, the cell should be more sensitive to our treatments. And that was the basis of the treatments used today. So people would have their surgery, and then they'd have their chemotherapy. And we were able to demonstrate that that cut down the risk of breast cancer by around half, taking it as a whole. So look at the transition that we've had. We've gone from a disease that was thought to be out of control. Nothing was going to control it, so you had to kill every last cancer cell, to where we had to have the most extensive surgery we could manage, and we had to give systemic therapy now to treat it as a systemic disease rather than a disease that's local and out of control. Well, that took us a long way. And then people started to think a little bit further about the way cancer acts. And remember, I said at the beginning, the notion was that the cancer cell, once it started, is out of control. And unless you kill the last cancer cell, it's going to win. Well, there were bits of evidence again that suggested that was not the case. Some of it came from the treatment of acute leukemia and the lymphomas, where you would see people who were clearly free of their disease many years out, but with very sensitive tests, you could find cells that looked like those original leukemia or other cells in the circulation. We also learned that an immune response played an important part, certainly in the leukemias and lymphomas. So there was a sense that it wasn't so much killing the cells as reasserting control. Or as I would often say when I gave my talks about this, you know, those of us who are parents have teenagers. And there are times you want to kill them. But actually what you really want to do is put boundaries on them and control them till their own control mechanisms kind of take over. And that's a little bit like the hormone story of giving the stilbestrol or giving the tamoxifen or giving the aromatase inhibitors, the Arimidex. These aren't so much cancer-killing drugs as metabolic control drugs, controlling the whole process in a way like thyroid or diabetes or some of the connective tissue diseases. So now what we're seeing in breast cancer is a recognition that this is, and in all cancers, that it's not so much about killing the last cancer cell as reasserting control. So we've gone through a period of time where first all the drugs were about killing cancer cells, and now most of the new drugs are about identifying the defect in the control mechanism, the defect in the metabolism that allows cells to divide, that allows cells to camp out in other places, that allows cells to live longer than they should normally live because there's turnover of cells in the body. If we can get to those control mechanisms and target them, you can reassert control. And that's, in fact, in many ways how the hormones work. It's how a lot of the new chemotherapy drugs work. They're not so much killing cancer cells as reasserting control. So where have we come in the history of breast cancer? From a disease that was thought to be totally out of control and that spread widely in a circumferential way, and the bigger the surgery, the better, to where we now understand that it's a systemic disease that starts in the breast. The surgery is important for diagnostic more than therapeutic purposes, and that our treatments not only delay recurrence and prevent recurrence, they help the body reassert normal control. So that's a huge transition, and the net effect is we've cut the morbidity and mortality of breast cancer in round numbers by between 50 and 75%. We've very much diminished the disfiguring surgery. And unlike the days when I was a kid, when if a woman had breast cancer, she kind of disappeared. I remember walking home as a teenager, and I knew that friends of my parents down the street, the woman had had a breast cancer and she had disappeared from sight. And you'd ask, how is she? Oh, she's fine. And I'm walking home one day and a car goes by, and who's driving the car? That lady. And I said, my goodness, I used to see her all the time because she was a friend of my parents, but I don't see her anymore. And this is a revelation. And I went home and told my parents I saw this lady. Well, think of the change now. Breast cancer is not something you wish on anyone, but people are alive. People are part of the community if they've had breast cancer. Some of you may remember the absolutely remarkable Time magazine cover photograph of the model Verushka, who'd had a mastectomy in her day and posed nude for Time magazine, a sign of the coming out and the return to normal life. That's maybe the biggest change in many ways in the whole history and sociology of breast cancer. It's a disease that used to take women's, not only their lives, but took life away from them. And now it's so different. So I'm going to stop there. And if there are any questions, I know that if we were sitting in the lecture room or in the one of the exercise rooms at Toronto Rehab, I would have been interrupted about 42 times. But if there are any questions, I'll try to do my best to answer them. And I'm going to just take a look at the chat line and see if we have any questions in there. I don't see any at the moment.
If you want, we do have a couple of questions that were submitted in advance that if you wanted to start with those, Dr. Schipper, we could,
Sure.
And maybe those will get some other questions going. I'll
Okay.
just try to change my screen here. There we go. Can you see those?
Yeah, I just have to diminish this polling question thing. Hang on.
Sorry, yeah, you can just
Yeah,
close it.
that's okay. All right. What are the chances of recurrence? Well, remember, I said early on that one of the things we've learned is that not all breast cancers are the same. We now have genetic information, ER, PR, HER2 information that allows us to much more accurately predict the likelihood of a tumor coming back. And as I would often say, there's some things my grandmother knew, you know. You would occasionally see someone, occasionally see women who came in, and they would tell a story that says something like this: I've had this lump in my breast. It's you know, the size of a small apple now. I've had it for 2 or 3 years. It's growing really very slowly, and I haven't done anything about it because my husband's been very unwell. And lo and behold, it turns out to be a breast cancer that's 2 or 3 centimeters or even 2 or 3 inches in size. And it may not even have invaded. It may have been a large ductal carcinoma in situ, but it's been there for a long time and growing very slowly. At the other extreme, you see someone who may have had a mammogram 3 months ago, and that mammogram was normal and there was nothing to find. And they come to the office because over the past 2 or 3 weeks, they've had pain in the breast, it's become red, it's become inflamed, and it's become hard. And that turns out to be another kind of breast cancer. Clearly, as my grandmother would have said, those tumors have to be different biologically. So, the chance of recurrence is a function of that biological difference. And our appreciation of that biological difference determines the treatments we use. So what were the first things we used to measure, if you will, to look at the risk? We'd look at the size of the tumor. We would look at it under the microscope to see how disorganized it was. We would look to see whether it had spread to the lymph nodes under the arm or elsewhere, and some other anatomic things around. In addition, as the technologies became available, we started to measure estrogen receptor and progesterone receptor, and in later years still, HER2/neu, which is another kind of hook. If you had a tumor that was strictly within the breast, and it was less than 2 or 3 centimeters in maximum diameter, we would call that a stage 1 tumor. If the tumor had spread to the lymph nodes under the arm, we would call that a stage 2 tumor. If it had spread more widely through the body, that would be called stage 4. And stage 3 is a funny classification for a breast tumor that's more extensive locally. We don't use it all that often. A stage 1 tumor, pardon me, if you do nothing about it, has about a 25% or 30% chance of recurrence. A stage 2 tumor has a 50 or 60% chance of recurrence, all this depending on how big it is and how many lymph nodes are involved and all that kind of stuff. So you can well understand that the higher the risk of the tumor coming back, the more intensely we're going to consider giving treatment. Once you've had your treatment, the risk of the tumor coming back is diminished by somewhere around 2/3 or 3/4. So if your tumor originally had a 25% risk of recurrence, the likelihood of it coming back in the next 10 years or so is 8 to 10%. If you had a tumor with a higher risk of recurrence, then the benefits of the treatment are greater, but the chances of recurrence remain greater. And we watch for that, and there are other interventions. So, someone's also asked, does the numbness and tingling in my hands and feet get better once treatment is done? Well, that really depends on the cause of numbness and tingling. The commonest cause is the use of a particular chemotherapy family of drugs called the Taxanes. And the Taxanes are complex products whose origin actually was in the tip of the Pacific yew tree. And originally it was manufactured from those harvested tips, but now it's synthesized. And it's a very potent, very effective drug. But one of the things it can do is damage peripheral nerves in funny ways, and it's very idiosyncratic. Some people don't have those side effects at all, and other people have them, and they can be really very troubling and last a long time. So I'm going to give you a waffly answer. Most of the time, the numbness and tingling goes away once the treatment is done and after a bit of time passes. Sometimes the numbness and tingling really persists, and there are all sorts of tricks we can do to minimize it, but I wouldn't be being honest with you if I said other than for a small number of people, it can be very persistent and very long lasting.
Dr. Schipper, you do have a couple of questions in the live Q&A chat there if you want.
Okay. Oh, wait a sec. I went to the wrong box. So give me a sec here. So I'll read the three questions, okay? Where is research taking us today and tomorrow? What is the relationship of a cancer patient developing diabetes? And how does radiation for breast cancer impact the heart? So let's say I go backwards and start with the last one. We try to keep the radiation dose off the heart. And so, as you know, the heart is left of center in the body in 99.9% of people. And so a cancer involving the left breast inspires a little more caution on our part about how that radiation treatment is given. With modern treatment, very little radiation actually gets to the heart. The beam is actually aimed more through the breast than through the body. And my radiation oncology colleagues have all sorts of fancy gear that shapes the field of radiation really very precisely. So often a little corner of the lung may be caught, leaving no symptoms at all other than maybe a transient cough for a few weeks, and enough to startle a radiologist many years later if you go and have a chest x-ray and they see this little bit of scarring and they don't know the history. So we pretty much keep it off the heart. The right side is a non-issue. That having been said, in people who've had radiation in bygone days when the fields couldn't be shaped that well, there were hazards of radiation damage to the heart, and it could present as premature coronary artery disease. And actually, we saw that a lot in the Hodgkin's patients because of the way the radiation treatment had to be given. But for the most part, it's not a problem now. The modern technologies are really very slick. I hope that answers the question. The next one was, what's the relationship of a cancer patient developing diabetes? Well, the treatment for breast cancer, so let me start by saying, to my knowledge, there's no relationship between having diabetes and developing breast cancer or vice versa, okay? They're independent events as best we know. What's the likelihood of getting treatment for breast cancer making your diabetes more difficult to manage in the short term? Well, of course, that depends on the treatment you're being given and is something that you really have to consider. So, for example, if you're a diabetic and you're working hard to control your blood sugar, particularly if you're a type 1 diabetic and you know, you're adjusting your insulin all the time, then some of the anti-nausea medications like steroids can send your glucose up, and the nausea and loss of appetite that may be associated with the treatment can put your diet off. So there's a juggling and balancing act that needs to be done. But beyond that, they're independent events, and one doesn't make the other worse. Where's research taking us today? Well, the big direction is the realization that we're dealing with a metabolically and genetically controllable event. So when you look at all the new drugs, we're at the tail end of drugs whose primary focus is killing the last cancer cell. We still use them. They're very effective drugs. So we use them with some of the new drugs that look at particular metabolic defects as identified by genetics and other things that turn on and off control mechanisms that lead cells to divide or to spread. There are also a class of drugs coming out called immune response modifiers. And these are drugs that try to tweak the immune system a little bit so that in addition to its usual role, your natural immunity starts to act against the cancer. And in a way, that goes back to the days of acute leukemia, where we learned, interestingly enough, that when you got your marrow transplant, and most of the time when you get a marrow transplant, it's not from a genetically identical donor. And the new cells, the new bone marrow cells, sometimes recognize the new host as foreign tissue and attack it in something called graft-versus-host disease. And what we learned is that in the leukemia setting, if you didn't have any graft-versus-host disease response at all, then the marrow transplant might not work and the leukemia would come roaring back. If you had a little bit of graft-versus-host disease, you were cured. So it's that kind of thinking from the standpoint of treatment. So the next question I suppose people are asking, particularly these days of COVID when everybody's thinking about preventions and immunizations, what do we do to prevent breast cancer? Well, breast cancer is largely a middle-class disease. If you look in developing countries with different nutritional statuses, it's not a black and white kind of thing, but you get a sense that this is a much less common illness. What are the factors that are considered? Diet, life habit, obesity, those kinds of things. So the notion that's actually built into the TRI program, apart from the exercise and what I mentioned earlier about exercise having a preventive role, and by the way, that extends to all sorts of diseases, not just breast cancer. But the notion that nutrition plays a role, and we're not talking about extremes of nutrition, not the people who never have any meat or only eat blueberries or the diet fad of the week. I remember my Latin teacher in grade 11 taught me one of the most important medical lessons ever, and that is the middle road. A moderate diet, well-balanced, not too much food, mixing it with exercise. that's the kind of thing we're starting to see. And you know, the rise in obesity in the United States, which is now the most obese country in the world, and more paralleled in China, where you're starting to see an emerging middle class in the larger cities, and obesity, and a rise in what you might call middle class diseases, you know, like heart disease and breast cancer. Those are the kind of prevention things. And no, we don't have a vaccine for it. It's interesting that we did do some clinical trials of both tamoxifen and the aromatase inhibitors called the breast cancer prevention trials. And here we took women who were thought to be at higher risk. We gave them, in a randomized trial, they were given either tamoxifen or in later trials, an aromatase inhibitor like Arimidex. And it cut down the likelihood of developing the cancer, but it had no impact on survival. And you know, it's not done very much these days because so many people would have to take so much of this drug for so long to have any impact that, you know, the risks and the benefits aren't there. What part does stress play in getting breast cancer? Well, nobody really knows. There was a famous physiologist who worked in McGill in the 60s. His name was Hans Selye. And he was the father of modern biological understandings of stress. And he made the important observation from animal studies that if you had no stress, you got sick. And if you had too much stress, you got sick. So you had to have a little stress. Sounds like my Latin teacher all over again. Following on that, there have been all sorts of studies over the years trying to get a handle on what impact does stress have on inducing a cancer or causing it to come back or make it worse. And one of the first difficulties is, how do you define and measure stress? Hard to know. And how do people react individually to it? What are the metabolic measures? You know, do you measure it in the immune system? Do you measure it in adrenal-like hormones, what we call the catecholamines? Do you measure it in resting heart rate? How do you measure it? So there isn't a good answer to that question, other than the very generic answer that when you live a very stressful life, when you don't have a balance, when you don't take a break, when you don't, you know, get some exercise, when you don't have an opportunity, a conscious opportunity to, you know, sit in the woods and watch the trees or meditate, you tend not to be well in kind of very general terms. I know it's a waffly answer, but it's the reality. And many of you may have seen the huge increase in the number of meditation programs that are available. One of the ones I know of and suggest to people who I go around the track with at TRI is one called Headspace. And Andy Petticombe was a crazy Buddhist monk who's built this remarkable meditation program that has millions and millions of users. And it's not so much that program as the buzz in the community of people who are finding time to chill out, to meditate, and it makes a big difference to them. So not a breast cancer answer, it's more of a philosophic GP answer, but there it is.
Dr. Schipper, I'm wondering if you could comment on the role of genetic testing for women with a first-degree relative with breast cancer.
Right, thank you. I forgot that one. You had it up. Somewhere around 8 or 10% of breast cancers have an identifiable genetic link. I choose my words carefully because genes are complicated things. there are very, very few illnesses where a single gene defect leads irrevocably to a disease. The one all medical students are taught about is sickle cell disease. About 30 years ago, in the early days of genetic testing, Marie Claire King in Seattle and a few others thought, I've got this new genetic, I'm now able to sort of, in a primitive way, look at the gene. And over in New York, there's an Ashkenazi Jewish community that has a very high incidence of breast cancer, and it seems to be familial. You draw the family tree, and 3 sisters have it, and they have kids, and many of the female kids have it, and as was learned later, the males may have prostate cancer. Why don't we take our new genetic kit over there and let's look at this population? And out of that came BRCA1 and BRCA2, or breast cancer associated gene 1 and breast cancer associated gene 2. And it turned out that many of these people with strong family histories did have one or another of those gene defects as detected by what were then very primitive, and I might add, very expensive tests. So that established that for a certain group of people, there were some genes that raised the odds. Now, it turns out it's not like that sickle cell gene, where one gene leads to a change in the hemoglobin in that disease. BRCA1 and BRCA2 are collections of genes, each on a different chromosome, and think about them as a toolbox to repair genetic damage. And every day our genes get damaged, just in the process of living. And the body has very sophisticated mechanisms for repairing that genetic damage. And imagine this toolbox has wrenches and screwdrivers and hammers and saws, and you take out the right tool for the right defect. Well, BRCA1 is a whole family of screwdrivers, hammers, and tongs, as is BRCA2. And some of those hammers, screwdrivers, and tongs are more commonly defective and more associated with a particular genetic defect than others. So that's the first class of people, and it's a small number of breast cancer patients. As genetic testing has become more accessible, cheaper, and much more precise, you can now measure every amino acid on the gene relatively inexpensively and quickly. You start to look to see, are there subtler defects? Could it be that if screwdriver A is bent and hammer B has a loose head, those two together start to make up an increased risk? So that data is starting to emerge. I think we can say with some confidence it's not going to turn out to identify a particular gene that is more powerful, but if you will, a relatively rarely seen one that may have a subtler influence. So from the standpoint of a genetic defect being predominant to the point where you want to do something about it in a prevention sense, we've got a fair bit of that at the moment, BRCA1, BRCA2, and a couple of others. Underlying it, though, comes the question, well, why does Mary get breast cancer and Sue not? And part of that is going to be lifestyle and environment. And part of that, in some manner, is going to be subtly your, if you will, genetic and metabolic heritage. And it's not as though you're going to be able to manipulate those very well. The people with BRCA1 and BRCA2, we now screen them more aggressively and sometimes do prophylactic mastectomies and oophorectomies. Who knows if down the line we'll find ways to, if you will, correct those genetic abnormalities in a preventive way, in the same way we do it therapeutically for other diseases, including breast cancer and chronic myelogenous leukemia and others. But if we're going to do that, we have to be pretty careful that the attempted prevention doesn't have adverse effects down the line, because now you're talking about something you may want to do very early for a life that may extend another 90 years.
Well, thank you so much, Dr. Schipper. As we near 11 o'clock, we are going to come to a close, but we thank you so much for being with us today, and we are hoping to have you back soon. So thank you again so much, Dr. Schipper. We really, really appreciate you being with us today. And as I said, we will have him back soon. So keep your eyes and ears open for that. I do want to announce that next Tuesday, we will have another live exercise class, and we're very excited about this. Lauren Jenkinson, one of our cardiac rehab supervisors, will be leading the live exercise class, and she's calling it ABCs of Exercise, 26 ways to add activity to your day, introducing an exercise for every letter of the alphabet so that you can squeeze some physical activity into whatever time you have available. So please join us for that live exercise class next Tuesday morning. And then finally, I'd like to invite everybody to register and join another wellness webinar being held tomorrow at 12 o'clock. You can register at www.healthinnovationseries.com, and I'll just leave this slide up for a second so you can jot that down if you want. And really the panel is going to talk about why exercise is critical, both as a strategy and a tool to promote good health and well-being. And this is for a variety of different populations. So please join for that webinar. With that, we're going to close, and I thank everybody for joining us today. Have a wonderful day.